Your blood sugar has been elevated at some point today. That is not a guess. It is a statistical near certainty for any adult living on a modern Western diet. And for the majority of those watching this video, it has been happening repeatedly, daily, for years, not at the dramatic levels that produce a diabetic emergency. At the subtler sustained levels that do not trigger any alarm, do not produce any immediate sensation, and do not show up as abnormal on a standard annual blood test, because that test measures your fasting glucose at a single point in time and tells you almost nothing about what your blood sugar is doing in the hours after every meal, which is when most of the damage accumulates. Chronically elevated blood sugar, even at levels that fall below the clinical threshold for a diabetes diagnosis, damages blood vessels, inflames nerve tissue, impairs kidney filtration, clouds the lens of the eye, and progressively disrupts the hormonal system that regulates appetite, metabolism, and energy. It does this quietly, predictably, and over years rather than days, which is precisely why the signs it produces are so consistently dismissed, misattributed, or explained away as the ordinary consequences of aging or a busy life. The blurred vision that clears on its own, the thirst that seems explained by the weather, the fatigue that appears after lunch, the tingling in the feet that comes and goes, the wounds that heal just a little more slowly than they used to. These are not random symptoms, they are a coherent physiological pattern, the body communicating through every system that glucose toxicity touches that something in the metabolic environment has shifted in a direction that requires attention. Most people who experience several of these signs have no idea they are connected and have never been told what connects them. That is what this video is going to change. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years in the AANDE, I have seen what chronically elevated blood sugar looks like when its progression is complete, the diabetic foot that required amputation, the stroke in a patient whose HbA1c had been quietly climbing for a decade, the renal failure in a patient whose kidneys had been taking a glucose-driven inflammatory hit every day for 15 years, the retinopathy that cost someone their driving license before anyone had explained what their blood sugar was doing to their eyes. These are not sudden events, they are the endpoints of a trajectory that announced itself through exactly the kind of signs we are going to discuss today. Signs that were present, that were real, and that nobody connected into the picture they were forming. My goal is to give you that picture before the trajectory completes. If you are watching this video, something in it has already resonated, a symptom you have noticed, a concern you have carried, or a pattern in your own body that has not been clearly explained. I want to make you a direct promise. I will keep creating the most rigorously researched and clearly explained content I can, grounded in a decade of frontline clinical experience and the latest evidence in metabolic medicine. All I ask in return is that you give this channel a genuine chance and hit the subscribe button right now. If you reach the end of this video and feel you have not learned anything meaningfully new, please unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from nearly 10 years in emergency medicine. Please hit subscribe, help this channel reach more people who need it, and let us get into it. To understand why elevated blood sugar produces the specific signs it does, we need to understand glucose regulation well enough that each sign becomes biologically logical rather than simply a warning to memorize. The signs are not arbitrary. Every single one is a predictable downstream consequence of a specific mechanism through which excess glucose damages or disrupts the tissue it contacts. Glucose regulation works through a tightly controlled feedback system centered on the pancreas, specifically on the beta cells of the islets of Langerhans, which are the insulin-producing cells. When blood glucose rises after a meal, the beta cells detect the rise and release insulin into the bloodstream. Insulin acts as a key binding to receptors on the surface of muscle cells, fat cells, and liver cells, unlocking their glucose transporters and allowing glucose to move from the blood into the cell, where it is either used for immediate energy or stored as glycogen or fat. As glucose clears from the blood, insulin levels fall, the glucose transporters close, and blood sugar returns to its fasting baseline. In a metabolically healthy person, this entire cycle from post-meal glucose peak to baseline return is typically complete within 2 hours. The problem begins when cells stop responding normally to insulin's signal. This state, insulin resistance, forces the beta cells to produce progressively more insulin to achieve the same glucose-lowering effect. For a period they succeed, Blood glucose remains within the normal range, but at the cost of chronically elevated insulin levels that produce their own downstream damage. Eventually, if insulin resistance continues to worsen without intervention, the beta cells cannot keep pace, and blood glucose begins rising first in the post-meal period, producing the 2 to 4 hour postprandial glucose spikes that a fasting blood test never captures, and then gradually in the fasting state as well, eventually crossing the clinical thresholds for prediabetes and then type 2 diabetes. What is critical to understand is that the vascular, neural, and organ damage associated with high blood sugar begins long before a diabetes diagnosis is reached. The mechanisms through which glucose causes damage, advanced glycation end product formation, oxidative stress, direct endothelial inflammation, and osmotic disruption of cellular water balance are active at post-meal glucose levels that standard testing does not systematically measure. Research published in Diabetology demonstrated that postprandial glucose peaks, even in non-diabetic individuals, were independently associated with cardiovascular event risk, retinal changes, and cognitive impairment, confirming that the damage spectrum begins below the diagnostic threshold and accumulates with each glucose excursion, not simply once a clinical label has been applied. Every sign of elevated blood sugar can be traced to one of 3 primary mechanisms through which excess glucose damages tissue. Understanding these mechanisms is what turns a list of symptoms into a coherent biological picture. The first mechanism is advanced glycation end product formation, AGs. Glucose is a chemically reactive molecule. At elevated concentrations, it spontaneously binds to proteins and lipids in a non-enzymatic process called glycation, forming structurally abnormal compounds that progressively accumulate in tissues. These AGs cross-link collagen fibers, making blood vessels stiffer and less elastic, and bind to specific receptors on immune and endothelial cells, activating inflammatory signaling cascades that damage tissue directly. HbA1c, the standard clinical marker for average blood sugar over 3 months, is itself a measure of glycation, the percentage of hemoglobin molecules that have been glycated by elevated glucose. The same process that raises HbA1c is simultaneously occurring in every other protein-rich tissue in the body, including the vessel wall, the lens of the eye, the peripheral nerves, and the kidney filtration membrane. The second mechanism is osmotic disruption. Glucose is osmotically active. In high concentrations, it draws water out of cells by osmosis, disrupting cellular hydration and function. In the lens of the eye, osmotic swelling changes the refractive index of the lens tissue, producing the blurred vision associated with acutely elevated blood sugar. In the kidneys, high glucose concentrations overwhelm the proximal tubule's reabsorption capacity and spill into the urine, drawing water with them osmotically, producing the increased urinary volume and the profound thirst that are among the most recognizable signs of significantly elevated blood sugar. In peripheral nerve cells, osmotic glucose accumulation activates the polyol pathway, a metabolic bypass route that generates sorbitol from excess glucose, and sorbitol accumulation in Schwann cells disrupts the myelin sheath that insulates nerve fibers, producing the peripheral neuropathy that begins as tingling and progresses to pain and sensory loss. The third mechanism is endothelial dysfunction and oxidative stress. Elevated glucose directly impairs the function of the endothelium, the thin single-cell layer lining every blood vessel in the body, by reducing nitric oxide production and increasing the generation of reactive oxygen species. Nitric oxide is the primary signal that maintains vascular flexibility and regulates blood flow. When glucose-driven oxidative stress reduces nitric oxide availability, vessels become stiffer, less responsive to flow demands, and progressively more prone to the inflammatory changes that underlie atherosclerosis. This mechanism is active in the microvascular beds of the retina, kidneys, and peripheral nerves, the tissues that lack the autoregulatory protection of larger vessels, which is why these 3 systems bear the earliest and most specific damage from chronically elevated blood sugar. Here are the 10 signs that your blood sugar may be chronically elevated, each one explained through the specific biological mechanism that produces it, so that you understand not just what to look for, but what your body is telling you and why. These 2 signs almost always occur together and are driven by the osmotic mechanism described in the science section. When blood glucose rises above the renal threshold, approximately 10 millimoles per litre in most adults, the kidneys cannot reabsorb all the glucose from the filtrate, and glucose begins appearing in the urine. Because glucose is osmotically active, it draws water into the tubular fluid, producing a larger volume of urine than the body intends to excrete, a process called osmotic diuresis. The resulting fluid loss triggers thirst through the hypothalamic osmoreceptors, producing the characteristic pattern of drinking more and urinating more. That is one of the classical presentations of significantly elevated blood sugar. The critical clinical point is that this sign indicates blood sugar has been elevated enough and long enough to exceed the renal threshold, not merely the threshold for vascular and neural damage, which is substantially lower. By the time thirst and polyuria are prominent, the blood sugar picture warrants urgent medical assessment. The post-meal energy crash, the pronounced fatigue that occurs 1 to 3 hours after eating, particularly after meals rich in refined carbohydrates, is one of the most common and most normalized experiences of metabolic dysfunction, and it is a direct consequence of the glucose-insulin dynamic in an insulin-resistant individual. When blood sugar spikes rapidly after a high glycemic meal, the beta cells produce a large compensatory insulin surge. In an insulin-resistant person, this surge frequently overshoots, driving blood glucose below the pre-meal baseline and into a transient reactive hypoglycemia. The brain, which is the primary consumer of glucose in the body and which is highly sensitive to acute drops in glucose supply, responds to this relative glucose deficit with the fatigue, difficulty concentrating, and craving for sweet foods that characterize the post-meal crash. This cycle spike overshoot crash is not simply a consequence of eating sugar. It is the functional signature of a glucose regulation system that has lost its precision, and it occurs at blood sugar levels that are not yet in the diabetic range. Transient blurred vision associated with elevated blood sugar is produced by the osmotic mechanism acting on the crystalline lens of the eye. When blood glucose rises acutely, osmotic pressure draws fluid into the lens, swelling it and altering its refractive index in a way that shifts the focal point and produces blurring that typically resolves as glucose normalizes. This osmotic blurring is distinct from and should not be confused with diabetic retinopathy, the vascular disease of the retinal microvasculature that develops with chronic glucose exposure, but it is an important early sign that blood sugar is reaching osmotically significant levels. Recurrent unexplained visual blurring that fluctuates across the day and correlates with dietary intake warrants blood sugar assessment as a primary investigation, not simply an optometry referral for a prescription change. Impaired wound healing is one of the most clinically significant consequences of chronically elevated blood sugar and is produced by a convergence of multiple glucose-driven mechanisms. Elevated glucose directly impairs the function of neutrophils, the frontline immune cells responsible for clearing bacteria from wounds, by reducing their chemotactic movement, phagocytic capacity, and oxidative killing ability. Simultaneously, Ag accumulation in the capillary walls of the microvascular bed reduces blood flow to the wound margins, depriving the tissue of the oxygen and nutrients required for collagen synthesis and cellular repair. Research published in Wound Repair and Regeneration demonstrated that even modest postprandial glucose elevations in the pre-diabetic range significantly impaired neutrophil function, reduced wound tensile strength in experimental models, confirming that the immune compromise of elevated blood sugar begins well before a clinical diabetes diagnosis. In clinical practice, recurring skin infections, boils, or fungal infections in someone who is not known to be diabetic should always prompt metabolic assessment, because glucose creates the permissive environment in which opportunistic organisms thrive. Peripheral neuropathy, the nerve damage driven by chronic glucose toxicity, typically presents first in the longest nerves in the body, which are those supplying the feet and lower legs, in a pattern clinicians call a glove and stocking distribution. The mechanism, as described in the science section, involves sorbitol accumulation in Schwann cells from the polyol pathway, combined with Ag-mediated damage to the vascular supply of the nerve and oxidative stress-driven mitochondrial dysfunction in the axon itself. The earliest symptomatic presentation is typically a tingling, pins and needles, or burning sensation in the toes and the ball of the foot, often worse at night when the peripheral circulation is relatively reduced. As neuropathy progresses, the sensation may shift to numbness, a more ominous sign because the loss of protective sensation creates the conditions for undetected foot wounds that are the primary driver of the diabetic foot complications I see in emergency medicine. Research published in Diabetes Care demonstrated that measurable neuropathic changes were detectable in up to 13% of individuals with prediabetes long before a type 2 diabetes diagnosis, underscoring the importance of treating peripheral tingling as a metabolic signal rather than a peripheral vascular or orthopedic one. Recurrent headaches in the context of elevated blood sugar arise through two distinct mechanisms that can operate independently or simultaneously. The first is the hypoglycemic headache, the headache that accompanies the reactive glucose drop that follows a significant post-meal spike driven by the cerebrovascular response to acute glucose reduction and the associated sympathetic activation. The second is the headache of sustained hyperglycemia, which reflects the osmotic effects of elevated blood glucose on cerebral fluid dynamics and the direct inflammatory impact of elevated glucose on the cerebral vasculature. Headaches that consistently follow meals, particularly meals high in refined carbohydrates, and that are accompanied by fatigue and difficulty concentrating, form a recognizable temporal pattern that points toward postprandial glucose dysregulation as the primary driver. This pattern is rarely investigated metabolically in the headache clinical pathway, representing a significant diagnostic gap. Paradoxical persistent hunger, the experience of feeling hungry again within 1 to 2 hours of a full meal, is a direct consequence of the hormonal disruption that elevated blood sugar and insulin resistance produce. Leptin, the satiety hormone produced by fat cells to signal energy sufficiency to the hypothalamic appetite center, becomes progressively less effective in a high insulin, high inflammatory environment as chronic insulin elevation downregulates leptin receptor sensitivity. Simultaneously, the reactive hyperglycemia that follows a glucose spike produces a genuine physiological hunger signal because the hypothalamus is responding to a real, acute drop in available glucose rather than to an absence of total body energy stores. The result is a person who is consuming adequate or excess calories, carrying adequate or excess energy stores, but receiving persistent hunger signals that do not accurately reflect their metabolic state, a hormonal disconnection between energy sufficiency and appetite signaling that makes dietary discipline a neurobiological challenge rather than simply a motivational one. Chronically elevated insulin, the pancreatic response to sustained insulin resistance, is the most potent fat storage signal in the human body. Insulin promotes glucose uptake into fat cells, stimulates the synthesis of new fatty acids from excess glucose through a process called de novo lipogenesis, and actively suppresses lipolysis, the breakdown of stored fat for energy. When insulin is chronically elevated, the fat cell is biochemically instructed to store and not to release, creating a metabolic environment in which fat accumulation is the path of biological least resistance, regardless of caloric intake. This is the mechanism through which caloric restriction alone consistently fails for individuals with significant insulin resistance, not because the caloric deficit is insufficient, but because the hormonal signal governing fat mobilization is overriding the caloric signal. Research published in the American Journal of Clinical Nutrition demonstrated that dietary interventions which reduced post-meal insulin responses produced greater fat loss than calorically equivalent interventions that maintained high insulin responses, even with identical total caloric deficits, confirming that insulin dynamics, not simply calories, are the primary determinant of fat mobilization in insulin-resistant individuals. AloneThis nigricans, the darkening and thickening of the skin in body folds, particularly the back of the neck, the armpits, and the groin, is one of the most specific and most overlooked cutaneous signs of insulin resistance, and it has a direct mechanistic explanation. Chronically elevated insulin stimulates insulin-like growth factor receptors on the keratinocytes, the primary skin cells in these body fold regions, driving their proliferation and producing the characteristic velvety, hyperpigmented thickening that is visible to the naked eye. The distribution pattern reflects the regions where skin-to-skin contact and warmth create the microenvironment in which insulin receptor density and IGF-1 receptor expression are highest. AloneThis nigricans is not a cosmetic issue, and it is not caused by poor hygiene, both of which are damaging and incorrect attributions that delay appropriate metabolic investigation. It is a dermatological readout of insulin resistance, and its presence in an adult without a prior metabolic diagnosis should prompt immediate fasting insulin, fasting glucose, and HbA1c assessment. Glucose is the primary energy substrate for Candida albicans and the dermatophyte fungi responsible for skin and nail fungal infections, And elevated blood glucose creates a biological environment that dramatically favors their growth. Oral thrush, vaginal candidiasis, intertrigo in skin folds, and onychomycosis, fungal nail infection, all occur at significantly elevated rates in individuals with undiagnosed or poorly controlled elevated blood sugar for two compounding reasons. The first is the direct nutritional advantage that excess glucose provides to these organisms in mucosal and skin environments where they compete with the host's normal flora. The second is the impairment of the innate immune defenses, particularly neutrophil and natural killer cell function that elevated glucose produces, reducing the body's capacity to contain opportunistic fungal proliferation. Research published in Diabetes Research and Clinical Practice demonstrated that recurrent vulvovaginal candidiasis was significantly associated with elevated HbA1c and postprandial glucose even in women without a formal diabetes diagnosis, identifying this pattern as a clinically underutilized indicator of undiagnosed metabolic dysfunction. If you recognize several of these signs in your own experience, the pathway forward is clear and accessible. A blood test measuring fasting glucose and HbA1c, combined, ideally, with a fasting insulin level, gives a far more complete picture of your metabolic status than fasting glucose alone. Many of the most consequential changes in blood sugar regulation occur in the post-meal period and at the level of insulin dynamics, neither of which a standard fasting glucose measurement captures. These are tests worth requesting specifically and by name. If this is connecting signs you have been experiencing to a metabolic picture you were not previously given, please take 5 seconds to hit the subscribe button. It genuinely helps this content reach more people who need it. Now let us talk about what the evidence says actually works to bring blood sugar under control and reverse the underlying insulin resistance. I want to be direct before we proceed. If you are currently on medication for blood sugar management, metformin, SGLT2 inhibitors, GLP-1 agonists, or insulin, nothing in this section is a reason to adjust your medication without your doctor's involvement. The interventions I am about to describe address the biological mechanisms of insulin resistance at their root and work alongside medical management, often allowing medication needs to be re-evaluated over time as metabolic function improves. That re-evaluation is a clinical conversation, not a unilateral decision. The most impactful dietary intervention for blood sugar control is not caloric restriction. It is reducing the speed and magnitude of post-meal glucose excursions by changing the composition, structure of meals. The glycemic response to any meal is determined primarily by 3 factors: the total carbohydrate load, the type of carbohydrate, with refined carbohydrates producing faster and higher glucose rises than intact, fiber-rich whole food sources, and the macronutrient context in which those carbohydrates are consumed. Protein, dietary fat, and dietary fiber all slow gastric emptying and glucose absorption, blunting the post-meal spike and the compensatory insulin overshoot that follows it. Research published in Cell Metabolism demonstrated that starting a meal with vegetables and protein before consuming carbohydrates produced glucose excursions that were up to 37% lower than the same meal consumed in the conventional order, a finding with immediate practical application that requires no special food, no caloric counting, and no dietary restriction. Time-restricted eating. Confining food intake to an 8 to 10 hour window aligned with the waking period produces further improvements in insulin sensitivity by extending the overnight fasting window during which insulin levels fall to their physiological nadir and the cellular machinery governing glucose uptake is reset. Research published in Cell Metabolism demonstrated significant improvements in fasting insulin, HbA1c, and postprandial glucose responses within 12 weeks of time-restricted eating in overweight adults with metabolic risk factors without caloric restriction. A 10 to 15-minute walk in the 30 minutes following a meal is one of the most evidence-supported and least prescribed interventions for postprandial blood sugar control, and the mechanism is direct and specific. Skeletal muscle is the largest glucose sink in the body, responsible for absorbing approximately 80% of post-meal glucose in an insulin-sensitive individual. During muscular contraction, glucose transporter type 4 GLUT4 is translocated to the muscle cell surface through an insulin-independent mechanism, allowing glucose uptake without the need for additional insulin signaling. This means that post-meal physical activity reduces blood glucose through a pathway that bypasses the insulin resistance that is impeding the normal glucose clearance route. Research published in Diabetologia demonstrated that a 15-minute walk after each of the 3 main meals produced a greater reduction in daily postprandial glucose excursions than a single 45-minute walk at any other time of day, confirming that the timing of physical activity relative to meals is as important as its total volume for blood sugar management. Progressive resistance training is the most powerful sustained intervention for improving insulin sensitivity at the cellular level, and its mechanism extends well beyond the acute glucose-lowering effect of post-meal exercise. Resistance training increases the mass, density, and glucose transporter expression of skeletal muscle, expanding the total glucose sink capacity of the body and improving the efficiency of insulin-mediated glucose uptake in every subsequent meal. Research published in the New England Journal of Medicine demonstrated that resistance training in adults with type 2 diabetes produced reductions in HbA1c equivalent to those achieved by a commonly prescribed oral glucose-lowering medication, with the effect accumulating over 16 weeks and persisting for months after the training period ended. The mechanism, increased GLUT4 expression, improved mitochondrial density in muscle, and reduced intramyocellular lipid accumulation, represents a fundamental improvement in the cellular architecture of glucose handling, not simply an acute energy expenditure effect. The glycemic consequences of sleep deprivation and chronic stress are among the most consistently underappreciated drivers of blood sugar dysregulation, and they operate through mechanisms no dietary intervention can fully compensate for if they are left unaddressed. A single night of sleep restricted to 4 hours reduces insulin sensitivity by approximately 25% the following day, the magnitude of effect associated with early type 2 diabetes through cortisol-driven hepatic glucose output, growth hormone-mediated insulin antagonism in peripheral tissue, and the direct impairment of beta cell insulin secretion dynamics that sleep deprivation produces. Chronic psychological stress maintains cortisol and adrenaline at levels that drive hepatic gluconeogenesis, the liver's production of new glucose from non-carbohydrate precursors throughout the day, raising fasting and post-meal glucose independently of dietary intake. Addressing sleep duration, sleep architecture, and the stress-driven HPA axis dysregulation that we covered in the brain stress video on this channel is therefore not a peripheral lifestyle consideration in blood sugar management. It is a primary metabolic intervention with a magnitude of effect that is comparable to significant dietary change.